Hello everyone. We want to welcome you to the presentation titled, Do Preoperative Nerve Blocks Prevent Phantom Breast Sensations Following a Mastectomy? A Systematic Review by Madeline Bywater and Kaitlyn Hayes. An introduction into our topic. An estimated 379,000 men and women in the United States will be newly diagnosed with breast cancer in 2025, with women disproportionately affected. Breast cancer represents nearly 16% of all new cancer cases in the United States. Women under age 50 have experienced the highest rate of increase at 1.4% annually compared to 1% across all age groups. And despite rising incidence rates, there has been a decline in overall breast cancer mortality. This downward mortality trend correlates with improvements in screening and treatment advancements. Surgical options, including mastectomy, continue to evolve and diversify treatment options. However, mastectomy is not without drawbacks, including the potential development of phantom breast syndrome. Alternative terms are phantom breast pain, post-mastectomy pain syndrome, phantom mastectomy pain, phantom sensations after mastectomy, and breast neuropathic pain syndrome. The problem we are researching within this study is that the exact incidence of phantom breast syndrome is unknown. It's estimated to be as high as 80% in patients following a mastectomy, and a rising incidence of breast cancer coupled with improved survival rates may increase the number of patients at risk for experiencing phantom breast syndrome post-mastectomy. The absence of standardized diagnostic criteria and a clear clinical definition for phantom breast syndrome leads to inconsistent reporting. So the purpose of this systematic review explores whether preoperative nerve blocks reduce the incidence of phantom breast syndrome in patients who underwent a mastectomy. Criteria for studies in this systematic review. Inclusion criteria. Pain description had to fit our definition of phantom breast syndrome listed in the following slide. Study designs included were cohort studies, case control studies, prospective cross-sectional studies, and randomized control trials, English language and full text original. Exclusion criteria, case reports, protocols, commentary, conference abstracts, letters to the editor, animal studies, cell studies, and cadaver studies were excluded. All other breast cancer surgical procedures that were not a mastectomy, articles older than 10 years, and studies focusing only on acute pain. Phantom breast syndrome defined. Phantom breast syndrome includes both phantom breast sensations and pain. This phenomenon occurs after the complete removal of breast tissue, either through a single mastectomy or a double mastectomy. The sensations or pain may begin as early as 1 month after the surgery, once the acute phase has passed. And the phenomenon may be described as a range of sensations from non-painful to painful, such as pruritus, pinpricks, tingling, tension, burning, shocking, pressure, stabbing, throbbing, electrical shock, and premenstrual type discomfort of the full or localized aspect of a breast that is no longer there. Search strategies. Systematic literature search was conducted from August to November of 2024. The search engines we utilized were Madeline, Central, CINAHL, and Embase. The search was conducted by 2 doctoral nurse anesthesia students. The 2 students met with a university librarian to discuss the search and results, and the initial search yielded a total of 440 articles. Literature selection. The software Zotero removed 138 duplicate articles. 302 records were screened by title and abstract. 2 reviewers independently evaluated the quality of 48 full-text studies using the Joanna Briggs Institute for Critical Appraisal checklists. During the full-text review, 2 additional articles were identified via reference searching. 14 studies that met inclusion criteria were included in the final analysis. In the following slides, we will be discussing a variety of nerve blocks.
Please refer to this slide for the full name of each block if any abbreviations are unfamiliar.
Results and discussion. Although outcomes vary across studies, several blocks have demonstrated effectiveness in reducing chronic pain following mastectomy. The pectoralis nerve block type 1 combined with the serratus anterior muscle block reduced numbness and hyposthesia and positively impacted depressive symptoms postoperatively. The PEX 2 block significantly lowered the incidence of chronic and neuropathic pain when compared to general anesthesia. The ESPB and the TIFPB reduced phantom breast pain, with both blocks outperforming the control group in lowering chronic pain incidence at 3 and 6 months post-mastectomy. The multi-level thoracic paravertebral block administered before surgery significantly lowered the incidence of chronic post-surgical pain and neuropathic pain. In contrast, SULAC showed no meaningful differences between the SAPB and control groups in reducing chronic pain or improvements of quality of life. The SATTMPB also showed inconclusive results. Similarly, the SGB, despite showing some reductions in post-mastectomy pain syndrome, was limited by a lack of consensus on the definition of pain syndrome, which might undermine its effectiveness. Authors' conclusions. PEX 1 plus SAM did show a reduction in post-operative numbness and hyposthesia. PEX 2 did significantly lower the incidence of chronic and neuropathic pain. ESPB and TIFPB did reduce phantom breast pain at both 3 and 6 month post-operative intervals. The TIVB plus continuous infusion did demonstrate substantial reduction in phantom breast pain at both 3 and 12 months post-operatively. Limitations, strengths, and challenges. First off, limitations. The absence of a widely accepted, standardized definition. Some of the studies in our systematic review did define chronic pain. Anesthetic techniques differed between each study. Next is strengths. Several articles included within the systematic review have a robust study design, such as randomized controlled trial or cohort study, which reduces bias and improves reliability of outcomes. Another strength of the articles displayed was the use of validated and reliable tools such as DN4, SF36, and the PHQ-9 to ensure accurate data collection. Finally, challenges. The lack of standardized criteria was hindered the systematic review's ability to draw clear conclusions and advise practice. It has also made it difficult to compare results across different studies. Authors' recommendations. A standardized and widely recognized definition of phantom breast pain is essential for improving consistency, clinical diagnoses, and patient care. Long-term follow-up studies are necessary to determine the sustained effects of nerve blocks on chronic pain outcomes beyond the initial postoperative period. Implications for practice. The body of evidence is limited by no universal accepted definition for phantom breast syndrome, ambiguity surrounding the diagnosis, small sample sizes, inconsistent methodologies, and lack of long-term follow-up. As such, no definitive recommendations for practice can be made. Implications for research. Future researchers should focus on adopting a standardized definition of phantom breast syndrome, as it is essential for improving research consistency, clinical diagnoses, and patient care. Long-term follow-up studies are needed to determine the sustained effects of preoperative nerve blocks on chronic outcomes beyond the initial postoperative period.